إلى 11 محاضرتكم. فأنا منزلة اللينك ودا أقول ساعة 10، فالمفروض كان تنبهوني إنه أنتوا جدولكم 9:30 وليس 10.
دكتور احنا هذا الجدول من الأسبوع الماضي وصلنا، فعبالنا واصلكم.
ما أنا ابني منزلة على السكرين، أنا الجدول اللي واصلني بال10 ونزلت لكم اللينك ودا أقول بال10، وكذلك اليوم ضفت اللينك الجديد وكذلك دا أقول بال10. يعني هذا الجدول اللي عندي. على كل، بسم الله الرحمن الرحيم. صباح الخير يا شباب، إن شاء الله دورة موفقة، و I wish you will enjoy this session this semester and you enjoy your pediatric hours. البوينت إنه you are short of time، لأنه الأسبوع اللي مضى انحسب عطلة فراحت من عندكم ساعة من المحاضرات. ف you need to bear with us because we are in press. We need to go somewhat hurriedly through our material. Our sessions, inshallah, we will cover some of the pediatric gastrointestinal problem. So a rapid glimpse about the GI tract of the infant and the child. This is a normal diagram of the gastrointestinal system. Is it shown? السلايدز هسه تبين يمكم؟
نعم دكتورة، واضح.
فير. الشغلة الأخرى يا شباب، يا ريت تنزلون أسماءكم على الشات ليست علشان تسجيل الحضور يعني. Anyhow, these are the divisions of the gastrointestinal system and the function of each organ system. You will receive a copy of the lecture later on, and these are the main functions of each part of the gastrointestinal tract, regardless whether it is a child or an adult. Starting with the esophageal anatomy, in the adult, it's a tubular organ it measures around 25 centimeters in length. Definitely it extends between the pharynx and the stomach. It runs a straight course within the mediastinum of the chest, and it pierces the diaphragm at the esophageal hiatus to enter the abdomen and the stomach. The function is to transmit the bolus of food from the pharynx down to the stomach. So this is done by progressive peristaltic movement in the esophagus. The esophagus is covered by two layers of muscles. The inner one is the circular muscle, which when it contracts, it constricts the esophageal lumen and it pushes the bolus of food downwards. The outer longitudinal muscle, when it contracts, it shortens the length of the esophagus, again helping to push down the bolus of the food. Another important anatomical landmark is what is called the esophageal sphincter, which is usually closed when we swallow the bolus, and it only relaxes to admit the bolus of food down to the stomach. Some peculiarities of the gastrointestinal system of the neonate and the child. نقصد يعني اختلافات أو أشياء يعتبر غريب عن adult gastrointestinal system. The infant usually develops suckling and swallowing as automatic reflexes initially. يعني involuntary reflex أقصد بالبداية. Gradually it comes under voluntary control as the nerves and the muscles develop around the age of 6 to 8 weeks. فبالبداية هو involuntary، يعني whenever you touch the angle of the mouth of the baby, he will try to grasp your finger, regardless whether he is hungry or not, because it's an involuntary reflex. Around the age of 6 weeks, this becomes under the control, voluntary control of the baby himself. Yani, he will open his mouth whenever he wishes to have a feed. The newborn stomach capacity initially is very small and it expands gradually. And the gastric emptying time, initially it is shorter than later in life. Some peculiarities about the stomach of the neonate in the child: it lies horizontally. It's around until the age of 2 years. بمعنى من تكون horizontal بمعنى البداية كالنهاية بنفس المستوى. This allows the backward movement of the stomach content very easily. لأنه الpylorus is lying nearly horizontal with the fundus of the stomach. In a horizontally lying baby, لأنه initially the baby lies in his mother's lap or in his bed, he is unable to sit in the upright position. So he is in a horizontal position most of the time. The gastric fundus is lower as the antral part of the stomach. This is what I was describing. The proximal part of the stomach, that is the fundus, it is lying nearly in the same level of the antrum and the pylorus. The baby usually have got lower esophageal sphincter with poor development of the mucous membranes and the muscular layer of this sphincter. So its tone is decreased or relaxed. بمعنى there is a weak lower esophageal sphincter in infants. While the pyloric sphincter is usually well developed. As you know, the pylorus is the end of the stomach. For the beginning of the stomach, the sphincter is lax. The end of the stomach have got a potent and strong sphincter. So this allows the stagnation somewhat of the feed in the stomach and probably even the backward movement of the stomach content. The fundus of the stomach is under the left dome of the diaphragm. Gastroesophageal reflux and regurgitation is frequent in infants. Due to all these previous factors that we have discussed, the end result is that newborns and young infants are more liable to develop gastroesophageal reflux than later in life. إذا أني عبرت نقطة بسرعة أو مو واضحة كانت you may comment حتى نرجع نوضح الأمور. Other peculiarities of the GI system of the neonate is that gastric acid secretions are deficient in several digestive enzymes, and they are usually not sufficient until 4 to 6 months of age. بمعنى gastric digestive ability is weak until the age of 4 to 6 months. The stomach pH is 5 compared to 2 in the adult, so less gastric acidity. There is a lower level of all the pancreatic enzyme activities اللي هم هذه مدروجة وتعرفون each one is concerned with the digestion of a certain food component. What other peculiarities? The infant's first stool is called meconium, which is a sticky and greenish black material composed of the intrauterine debris, such as bile pigment, epithelial cells, some fatty acids, mucus, blood, and amniotic fluid. The passage of meconium should occur within the first 24 hours. If it is delayed beyond that time, one would start suspecting certain disorders. The meconium starts to be passed within 24 hours. At the third day of life, it is followed by what is called transitional stool, which is a transitional material between the meconium and the normal following stool of the infant. So transitional stool, it appears at the third day after initiation of feeding. If the baby was sick and he didn't start feed, this will not show. Its color is greenish brown to yellow brown in color. It is less sticky than meconium, and it may contain some milk curds. The typical milk stool is passed usually by the 4th day onward. In breastfed infants, the stool is yellow to golden in color, and it is pasty in consistency, يعني مثل المعجون, with odor similar to that of sour milk. Sour milk نقصد حليب محمض. So it is golden yellow, pasty in consistency, and the smell is like sour milk. This is in breastfed babies. Babies fed on cow milk formula, the stool is pale yellow to light brown. It is firmer in consistency. ذاك قلنا مثل المعجون يعني semi-formed خلينا نقول. While it is harder, firmer in the bottle-fed baby, and it has got a more offensive odor. Breastfed infants usually have more stools than do bottle-fed infants. يعني if the bottle-fed passes 1 to 2 motions per day, a breastfed baby may pass up to 6 bowel motions per day normally without illness. The stool pattern can vary widely. 6 stools a day may be normal for one infant, whereas a stool every other day may be normal for others. And this is very common in breastfed babies. They do have, each baby have got his own habit. Some babies, they pass only a motion every, sometimes even per week, and still it's not constipated. It is soft and pasty. Others, they may have 4 to 6 motions per day, and still it's not diarrhea. This figure the figure A stands for meconium, اللي قلنا يصير greenish, dark green and pasty in consistency. This is the brownish for the bottle-fed infant and golden yellow for the breastfed baby. So starting with some sort of congenital abnormalities that may affect the gastrointestinal system of the infant is what is called esophageal atresia, esophageal fistula. So by atresia, we mean total obstruction. Obstruction is partial. This condition will be called stenosis. Atresia, it means total obliteration. So the esophagus is totally obliterated. There is a connection, a fistula between the trachea and the esophagus. This condition.
سلايد واقف.
لأنه حولته على فول سكرين. معناه نرجع على small screen. Showing.
اي دكتورة.
الظاهر النت ضعيف فمن دا أفتح السكرين فول ليتأخر الترانسميشن. على كل I hope it is clear بهذه الصورة الصغيرة. This condition occurs due to failure of the esophagus to recanalize between the 4th of development, يعني in utero, 4 to 6 weeks of gestation. The GI tract is a blind tube. It should canalize recanalization of this area within this age between 4 to 6 weeks of gestation ends in what is called the esophageal atresia. There is lack of communication between the proximal and distal esophagus لأن احنا قلنا atresia يعني total obstruction. There are many types of this defect, but this picture shown, it forms around 80 to 90% of the defects. The other types of esophageal atresia are much rarer. What you see now is that the esophagus have got an upper blind pouch, and the lower esophagus is connected by a fistula with the trachea. So this is another diagram presenting what we have been discussing. This diagram presents the most common type of the defect اللي هو نفسه بالصورة السابقة بالسلايد السابق. The esophagus have got a blind upper pouch, and the lower esophagus is connected by a fistula with the trachea. So from this picture, you can expect what is the problem to be anticipated. The baby will not be able to feed properly. Whenever he sucks, he swallows, the fluid will accumulate in the blind pouch. It will not reach the stomach. But because the lower esophagus is connected to the trachea, so air would reach for the stomach. الair راح يوصل للستومك بس الفود لا، لأنه احنا هذه قضايا نتبعها. Initially, the GI tract of the newborn is not aerated. When he starts crying and breathing, gradually air enters into the gastrointestinal tract and gradually reaching even to the colon within 6 to 8 hours usually. So with this type of defect, adnal esophagus, the blind upper pouch, it will prohibit, it will interfere with proper feeding of the baby, and the lower esophagus being connected to the trachea, it will have some air entry into the stomach. So the other types of esophageal atresia, ممكن both ends of the esophagus they end blindly, ماكو أي connection ويا البرونكيال tree. هنا الستومك ما راح يوصلها air، راح تبقى gasless abdomen ما بها أي air. The other type, this type is called the H-type fistula. The esophagus is not atretic, it is patent, but there is a fistula connecting the esophagus to the trachea, which will allow for recurrent aspiration of liquids and food, and usually it presents later in life as recurrent pneumonia and recurrent aspiration. While this common type of atresia and fistula, it is an emergency, it is incompatible with long survival if it is not diagnosed early enough and corrected surgically.
دكتورة
نعم.
دكتورة بالH type دينا presented late in life يعني بالchildhood لو
Usually yes, because the esophagus is patent, so it allows for feeding. He can feed, but he aspirates every now and then من الesophageal content راح يطفر راح يروح some droplets, it will pass to the bronchial tree and it will initiate aspiration pneumonia. Anyhow, this is a rare anomaly actually. This diagram shows the approximate percentages of the defect. The most common one اللي هو هذا C, between 80 to 90% of the defects هي من هذا النوع اللي blind upper esophagus with lower esophagus connected by a fistula to the trachea. You do not need to memorize the other figures, بس المفروض نعرف this is the most common one. It is a frequent congenital anomaly in general, the esophageal atresia, around 1 in 3,000 of live newborns. 1/3 of such anomalies, it occurs in premature babies. So how does it manifest? احنا قلنا most common type اللي هو هذا وصفنا blind upper esophageal pouch. So any upper GI obstruction usually presents with history of maternal polyhydramnios. And we mean by upper GI obstruction, any obstruction occurring above the ligament of Ladd. Ligament of Ladd, it divides the duodenum into an upper 1/3 and lower 2/3. فمن proximal 1/3 of the duodenum, upward وصولا إلى الpharynx. This is all upper gastrointestinal tract. Any obstruction affecting this anatomical area, it will lead to maternal polyhydramnios. So when we receive a newborn from such mothers, we need to check the patency of the upper GI tract of the baby. The other presentation would be the catheter of resuscitation, which is commonly used for suctioning debris from the mouth and from the stomach of the baby. Usually cannot reach for the stomach لأن احنا وصفنا الديفكت مثل ما تتذكرون upper esophagus هو blind pouch. Normally during resuscitation of newborns, they perform suctioning by catheter from the mouth, reaching down to the stomach to suck any swallowed debris from the birth canal. In this condition, with this defect, the catheter cannot reach for the stomach, and the health carer or the doctor will feel resistance when he tries to pass the catheter down to the stomach. Another important presentation, such babies, they have excessive frothy oral secretions. يعني يقولون حلقة يوقف. Excessive oral frothy secretions of mucus, which recur back very quickly after suctioning. فالusual response اللي يصير ويا النيرس أو ويا الدكتور, he will suck these excessive oral secretions. But in the presence of esophageal atresia, it recurs, it recollects very quickly. And this is another point that should lead the doctor to suspect the presence of such defect. The other presentation, which we hope that we do not reach for it, is choking and cyanosis or coughing with feeding. لأنه إذا الطبيب ما انتبه على هذه الثري previous presentation, the fourth event راح تصير, he will allow feeding. And since the esophagus is blind, obstructed, so the feed will not reach down to the stomach. So he will choke, لأنه هذا الshort pouch, it will be filled very soon with few milliliters of any liquid. And when it is filled, it will be spilled into the trachea. راح تطفر وتنزل بالtrachea. But this is why when he is offered a feed, he will choke. Choking يعني يغص أو يشرق بالعامية. And he will develop cyanosis or severe coughing with feed. The fifth event that should lead us to suspect the presence of such a problem, that 1/3 of such babies, usually they have other congenital anomalies, either or wherever. So how do we diagnose such a condition? Starting from the history of maternal polyhydramnios, resuscitating catheter cannot be passed down to the stomach. Attending physician will feel resistance when trying to push down the nasogastric tube down to the stomach, and the baby will show excessive frothy oral secretions recurring very rapidly after suctioning or after cleaning by a tissue. And the baby is offered a feed, he will develop choking and cyanosis and cough. Our main task is that to diagnose early this defect before allowing feeds for the baby, because feeding and he aspirates any of the feed, even if it is plain water. لأنه هذه الGI tract شباب, the baby will swallow many debris during passing in the birth canal. The contents of the esophageal pouch will be aspirated down to the bronchial tree, and it will initiate severe chemical pneumonia. Our role as pediatricians is to suspect the problem early, to avoid offering feeding to such babies until we fulfill the diagnosis documented the diagnosis, the treatment needs to be a surgical emergency. So, the surgery as soon as possible. When we stabilize the general condition of the baby, better to keep him in the prone position to allow for the secretion to fall out away with continuous suctioning, maintaining normal temperature, starting IV hydration, and emergent surgery even within few hours after birth. So, how do we fulfill the diagnosis? احنا أخذنا history we did observe the baby. He was frothy. We couldn't pass a nasogastric tube down to the stomach. The best way to document the presence of such a defect is to pass a radio-opaque nasogastric tube and have a chest X-ray after that to see that the radio-opaque nasogastric tube is coiled inside the upper esophageal pouch and it failed to reach down to the stomach. وياي هسه احنا قلنا الستومك بيها gas bubble يعني احنا قلنا lower esophagus عادة connected fistula رايح ويا التراكيا بس upper esophagus هو blind pouch كيس مغلق فنستعمل radio opaque tube لأن إذا مو radio opaque إذا ما بي هذا radio opaque line it will not show in the X-ray ما أقدر أشوفه ما أقدر أميزه عن ال soft tissues. I will try to pass a radio opaque tube وهنا مثل ما تشوفون هذا التيوب coiled يعني التوى أخذ الشكل مال الاسophageal pouch. sometimes during resuscitation إذا إحنا ما منتبهين ممكن نتصور إنه التيوب اللي ندفعه is reaching down to the stomach, but the fact that it is being coiled inside the esophageal pouch. So this is why it is better to use a radio opaque tube and to have a plain chest X-ray in order to see whether the tube is really going down to the stomach or it is coiled inside the upper esophageal pouch.
دكتورة عفوا بالاتش تايب هم راح يطلع لنا هذا الابيرنس؟
لا الاتش تايب ما يطلع. الاتش تايب التيوب راح ينزل يوصل للستومك فهالطريقة ما تنفع بالدايجنوسيس. بس هذه الطريقة لأنه هذه التايب of defect هذا emergency. It will show very soon within the first few moments after delivery. The H type is usually symptomless until late life. يلا it starts showing. لأنه الاسophagus is patent, feeding راح يمشي بس and then راح يصير small aspiration شوية راح milk droplets راح تعبر من الاسophagus to the trachea. هسه هنا هاي chest X-ray, the one on the left that تشوفون هذا coiled radio opaque tube بينما مقارنة بالother X-ray that تشوفون هذا radio opaque tube it is passing down to the stomach. هاي big gas bubble under the left dome of the diaphragm, usually it is a gastric bubble. So, the other congenital anomaly affecting the gastrointestinal system of the neonates is the diaphragmatic hernia, which is defined as herniation of the abdominal contents into the thoracic cavity. Again, it is frequent with an incidence of 1 in 2,000 of live-born babies. It forms 8% of all major congenital anomalies in general, مو بس GI tract. So diaphragmatic hernia is a frequent congenital anomaly. It occurs through 2 points in the diaphragm. The most common is the posterolateral segment of the diaphragm, which is called the foramen of Bogdalek. And usually in the left side of the diaphragm. So posterolateral and mostly on the left side of the diaphragm. The other less common defect is the retrosternal defect, which occurs through the foramen of Morgagni. This type of defect, it may present early in the neonatal period, and usually it is a severe defect. And milder defects, the presentation is usually delayed later in life. So when it presents in the neonatal period, usually it presents with severe respiratory distress, يعني dyspnea, and cyanosis, frequently from birth. فلهذا احنا any dyspneic baby should have a chest X-ray, because we cannot differentiate easily between, for example, congenital pneumonia or congenital hyaline membrane disease or congenital anomalies of the type of diaphragmatic hernia. مثلا. If in milder defects, it may present later in life in the shape of vomiting, discomfort after feed, because the part of the GI system have traveled into the thoracic cavity, stomach, some parts of the bowel even. So definitely the baby will be liable to vomit, to have a discomfort that is pain and fullness after feed, abdominal pain, and sometimes features of intestinal obstruction. The physical findings depends on the degree of the displacement. In severe degrees, the abdomen may look scaphoid. Scaphoid يعني خاسفة تكون لأنه many parts of the GI system have moved into the thorax. Respiratory retraction, sometimes shock, especially in the when the defect is in the foramen of Morgagni, because it's going to compress the heart. Percussion of the chest will be tympanitic because the bowel loops contain gas. من البowel loops قاعدة بالthorax, definitely when you percuss, it will be tympanitic, and sometimes bowel sounds are heard in the chest when you auscultate. Prenatal diagnosis is possible as early as the second trimester. And what is seen in the prenatal ultrasonography, there may be seen as mediastinal shift, لأنه الدفك راح يصير one side, قلنا most commonly بالleft side ده يصير. But usually there is a shift of the mediastinum. The abdominal organs may be seen above the diaphragm, the stomach, intestine, liver, etc. Poor prognostic signs if there is intrauterine growth retardation of the fetus, if there is significant polyhydramnios, if there is fetal hydrops. الفetal hydrops نقصد بها diffuse edema of the baby with ascites, fetal ascites. This stands for fetal hydrops. We mean hydrops fetalis نسميها. So this prenatal ultrasound shows here that the gas bubble of the stomach, or the cavity actually, not the gas bubble, the cavity of the stomach is lying at the same level of the cardiac chambers. معناته واحد قاعد بصف الله. Again here, the cavity of the stomach with Doppler تروينا at the same level of the cardiac chambers. هذه للإطلاع بس حتى تتخيلون هي شنو الصورة. Postnatal diagnosis, if it is an early severe defect, it will show in the neonatal period. There may be severe respiratory distress. The abdomen may be scaphoid. يعني أنه يعتمد أحيانا many of the organs, liver عابر والstomach عابرة والsmall intestine عابرة. Auscultation of the lung will reveal poor air entry, and there may be shift of the heart to the opposite side. احنا قلنا more frequently الدفكت يصير بالleft dome of the diaphragm، فغالبا يدفع الميدياستاينم to the right side، بمعنى الهارت it will be pushed to the right side of the abdomen. After birth, a plain X-ray may be useful also to document the presence of diaphragmatic hernia. واحنا قلنا الchest X-ray هي روتين لأي dyspneic baby، لأنه usually physical examination is uneasy to allow us to give a diagnosis. So again, it is better to pass a radio-opaque tube because you can localize easily the site of the stomach as the end of this radio-opaque tube. So this is a plain X-ray. You can see that the mediastinum is shifted to the right, هذا الهارت والمediastinum رايح للرايت. The left side is occupied by multiple air fluid levels. ده تشوفوها هاي مثل البابلز اللي occupying the whole left hemithorax. At the same time, this nice radio-opaque tube is reaching the stomach, بس الstomach وين قاعدة above the diaphragm. هذا الdiaphragm والstomach هي قاعدة هنا. This picture also the same. هنا هذا الدايجرام دايروينا شلون small intestine عابرة للupper chest, pushing the heart to the opposite side. So this is what we mean by a scaphoid abdomen. الabdomen is low, sunken, خاسفة بالعربي راح نسميها. Another plain chest X-ray down after birth. The mediastinum and the heart are pushed to the right, and the whole left hemithorax occupied by multiple air fluid levels. لأنه الintestine always it contains some fluid and gas. So on examination, the chest will appear barrel-shaped لأنه distal راح يكون so many organs دخلت بالthoracic cavity, abdomen sunken, bowel sounds may be heard in the chest by auscultation, sound are diminished, there will be severe respiratory distress. How do we manage such conditions after diagnosis? Better to keep him in a raised head and chest position حتى نحاول نسوي decompression. We reduce much of the organs down back to the abdominal cavity. Nasogastric suction is useful to decompress the stomach لأنه with crying and breathing the baby is going to swallow air which is going to distend the stomach further. With suctioning we suck the gas and the fluid from the stomach and we deflate the stomach distension. Many of them, they will need mechanical ventilation because such congenital defect frequently is associated with even hypoplasia of the lung. The compressed lung will fail to grow and to develop normally. So many of them will need mechanical ventilation for a while. They will have both metabolic and respiratory acidosis, and this condition needs to be corrected medically. And because the compressed lung may be hypoplastic, it means that it will develop pulmonary hypertension. So if there is features of pulmonary hypertension, it needs to be treated. Sometimes babies need extracorporeal membrane oxygenation for a while to correct their ventilatory defect and their pulmonary hypertension, and medical treatment for the acidosis and the pulmonary hypertension. So all these events are necessary to stabilize the baby before allowing for surgery, because the intraoperative mortality is very high if we do not correct the general condition of the baby. So fatalities in early presentations are high. Survivors may continue to have abnormal pulmonary function test. Because we said the early presentation, it means a more severe defect. Another congenital anomaly is the hiatal hernia. Two types of hiatal hernia are faced. One of the most common type is the sliding hiatal hernia. Here the defect is different from diaphragmatic hernia, is that the herniation occurs through the esophageal hiatus, while the diaphragmatic hernia الديفكت كان هنا دا يصير through the dome of the diaphragm يعني. So the most common type is the sliding type, which leads to a shortened esophagus and dragging of part of the stomach into the thoracic cavity. The stomach will be continuous with the esophagus. While the rolling or the paraesophageal hernia, it is much less frequent, where part of the stomach fundus, it herniates alongside, يعني beside the esophagus into the thorax. In such condition, it will be liable for strangulation لأنه هذا الherniated part will probably develop impairment of its blood supply. Such conditions, as you can notice هنا بالsliding hernia احنا فقدنا esophagogastric angle اللي احنا حكينا عليها بالبداية والسفنكتر هذا اللي قلنا it helps to prevent the backward movement of the stomach content. فهنا عندي الاسophagus short، ما عندي gastroesophageal angle الأكيوت angle اللي شفناها بالسلايدز الأولانية. this will allow for reflux, and refluxing the acidic gastric content into the alkaline media of the esophagus, it will make it liable for ulceration, bleeding, and dysphagia. So the main presentation actually of hiatal hernia is reflux, gastroesophageal reflux, because this other type is very rare actually. So what do we mean by reflux? When there is incompetence of the lower esophageal sphincter, it allows for the return of the stomach content into the esophagus. There are some different terms. Gastroesophageal reflux, it stands for the passage of the gastric content into the esophagus. While gastroesophageal reflux disease, we mean when gastric content reflux into the esophagus or oropharynx, it produces symptoms. When it is symptomatic, so it is called GERD. Another term which is frequent in infants and neonate is regurgitation, which means the passage of the refluxed gastric contents into the oral cavity. This is a simple and benign phenomena, and it occurs in many of the normal, healthy newborn babies. Usually, it occurs more when the baby is overfed. Vomiting is defined as the expulsion of the refluxed gastric content from the mouth, يعني to the outside. So why do babies develop reflux, which is this passage of the stomach content into the esophagus? Points I have been discussed mostly in previous slides. The barriers against the reflux هو lower esophageal sphincter والacuteness of the angle of the gastroesophageal angle. If the sphincter lacks the appropriate tone, or it is weak, incompetent, or there is gastric volume of pressure, يعني the baby is overfed, big volume of feed, أو عندنا obstruction بالdistal part of the stomach, it means there will be accumulation of the content. If there is poor gastric emptying, if there is altered neuromuscular innervation of this area, if there is abnormal esophageal motility, if there is loss of the acuity of the angle of His, and if the presence of other anatomical defects, for example, obstruction, stenosis affecting the distal part of the GI tract. In general, هذه بس فكرة دا تنطيكم ليش يصير reflux. أكو normal physiological conditions دا تصير بالنيونيت اللي حكيناها بالشرائح الأولى، وأكو ممكن تضاف إلها إذا عندنا gastric volume distension، عندنا obstruction بالdistal part of the gastrointestinal system. Reflux is a common condition involving regurgitation or spitting up, which is a passive return of the gastric content retrograde into the esophagus. The peak incidence of the reflux, it occurs between 1 to 4 months of life. And usually it resolves by the age of 12 months. لأنه هواية من الفيزيولوجيcal factors اللي حكيناها قلنا initially the baby, he lies in the supine position mostly, and the stomach will be in a horizontal position. with some weakness in the sphincter and poor development of the area of the mucus and muscular layer of the sphincter. All these factors will allow easy reflux. And this reflux, it will present as vomiting early in life, mostly between the age of 1 to 4 months. But with the passage of time, reflux mostly is improved by the age of 1 year. This because usually, هسه تلاحظون من هذا الدايجرام, after 6 months, usually prevalence declines gradually until the end of the first year. منها because the baby will start to obtain the sitting position at 6 months onward. منها he will start ingesting solid foods أكثر, and solids are more difficult to be refluxed and expelled than the liquid milk feeds. This is why normally this problem resolves with the passage of time. So what's the difference between reflux and GERD? Babies with simple reflux usually continue to grow normally, while if there are bad effects of this reflux creating problems to the baby, namely هي غالبا تصير على شكل esophagitis, usually there will be poor weight gain. With plain reflux, there are no signs or symptoms of esophagitis, while if there is esophagitis, راح نسميه GERD, he will be irritable, lower chest pain, dysphagia, hematemesis, and sometimes even iron deficiency anemia. They may develop fresh hematemesis, يعني fresh blood with the vomitus. In plain reflux, no significant respiratory symptoms. While with reflux disease, they may develop apnea and cyanosis. They may develop wheezing due to recurrent aspiration. Any condition which leads to recurrent vomiting, it may lead to recurrent aspiration. And aspiration may present as a wheezy chest. Again, the baby may present as recurrent pneumonia, as chronic cough, as stridor, due to the irritation to the larynx. With plain reflux, there are no neurobehavioral symptoms, while with GERD, infants may develop tilting of the neck, which is called the Sandifer Syndrome. The baby will try to reduce the irritating acidic reflux material into his esophagus, so he will try to stretch his esophagus. He will throw his head backward as if obstotenous position. He will throw his head backward, trying to stretch his esophagus, to lengthen the esophagus, to reduce down the irritating acidic material. So reflux disease, how does it present? Vomiting, pain, irritability, failure to thrive, recurrent hiccup, yawning, and sneezing. Severe symptoms may lead to pulmonary compromise, apnea, pneumonia, recurrent wheeze, asthma, stridor, bleeding, hematemesis, anemia, iron deficiency anemia, and the Sandifer syndrome. And this is what I mean by the Sandifer. The baby throws his head backwards in an attempt, محاولة, to lengthen the esophagus, to reduce down the irritating acidic gastric reflux. Again, this is Sandifer. هذا البوزيشن احنا نسميه obstotenous, اللي هي neurological abnormality. بس هنا ما عنده neurological abnormality. He is trying to lengthen his esophagus and to push down the refluxed, burning, irritating material. So you do not need to go through this. How do we treat them? By positioning. It's better to keep him in a head up position. We raise his head and back in the bed to reduce the possibility of reflux. It means we avoid laying him flat. Dietary measures, if he is bottle fed, thickening of the formula may be useful, but in both instances, whether breast or bottle fed, the best maneuver is to reduce the volume of the feed, that is giving him small and frequent feeds. Sometimes drug therapy is needed in the shape of antacids if there is a lot of irritation and bleeding and hematemesis. Antispasmodics may be useful. In severe and resistant cases, surgery may be required, and the surgery is called fundoplication in order to reduce the possibility of reflux. So, I think your time is through. We hope we can cover the rest of our subject in the coming hours. أكو سؤال؟
دكتورة دكتورة الطفل يعني من ليش يحاولون يسوون belching؟
belching you mean احنا بالعربي نقول يتجشأ يعني يتريع. belching يعني gases, expelling gases. بس أنا اللي قلته hiccup قلت مو belching. والhiccup is a very frequent presentation of reflux due to the vagal stimulation and irritation of the esophageal mucosa. In adults even, it is a very frequent manifestation of reflux. But it's a normal phenomenon, يعني it's not abnormal. Excessive gases will be excluded out of the stomach. بالعربي نقول يتريع يعني. بس hiccup it means الشهيقة هذه نسميها.
دكتورة الاسوفيجيال اتريزيا ممكن انه يصير عندنا هنت انه يجي فوميتنج عنده اول ما يجي للدنيا الحليب اللي يصير بريست فيدنج راسا.
اي بس انت المفروض انت تلوك قبل ما تنطي حليب and you allow him to vomit. المفروض ننتبه عليه لان من انطينا حليب وصار عنده aspiration هذا نسميه chemical pneumonia. الميلك اللي راح ينزل باللانج راح يسوي له chemical pneumonitis and this will reduce the prognosis of the surgery severely. يعني it will be followed by failure of surgery.
دكتورة يعني مو شوية صعب قبل لا نطي فيه هو أول ساعة من حياته راح يرضع يعني دكتورة؟
لا 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 بالعكس أبدا مو صعب لأن هذه البوينتس اللي ذكرت لكم إياها very clearly demonstrates كلش بسهولة ينتبهون عليها. he will be frothy يعني يوقف حلقة يزبد مثل ما يقولون. وكل ما تمسح النيرس كل ما يلم بسرعة رأسا. المذر إذا عندها history of polyhydramnios لازم أخلي ببالي يعني حتى عنده symptom ما عنده symptom I will pass an esogastric tube وأتأكد إنه الطريق مفتوح لو لا. والأفضل إنه التيوب يكون راديو أوبيك حتى ممكن أشوفه بالإكس راي فعلا وصل للستومك أم لا.
دكتورة بلا زحمة رفعنا الباوربوينت اليوم حتى نقراها.
إن شاء الله I hope إن شاء الله. أوكي شباب إذا ماكو سؤال إن شاء الله نشوفكم بالأسبوع القادم بس I hope إنه الكل سجلت أسماءها بالشات بوكس.
نعم دكتورة.
أوكي.
دكتورة.
نعم.
دكتورة اللي